Good morning, good afternoon. My name is Susanne Karay. I'm a consultant for child and adolescent health and quality of care at the WHO Athens Office for Quality of Care and Patient Safety. I would like to welcome you to the first of a webinar series, Future-Proofing Child and Adolescent Health in Europe and Central Asia. Today, we are going to focus on the WHO and UNICEF fact sheets that formed the basis for the evidence base for the strategy on child and adolescent health and well-being upcoming, hopefully to be ratified by the end of the year. I'm here joined by a nice lineup of distinguished speakers. And first of all, I would like to hand over to João Breda, the head of the WHO Athens Office for Quality and Care and Patient Safety, and the special representative to the regional advisor of WHO Euro and the officer in charge of the Greek country office for the opening of this webinar. João, the floor is yours.
Thank you so much for the nice and long introduction, Suzanne. And it's not your fault, of course. I'm delighted to be with you today. I'm also really excited to be here together with my colleagues from UNICEF, and also to really once again put forward and highlight this excellent collaboration we are having. I think this is really an important webinar on child and adolescent health in the context of a series of events. The focus on future-proofing child and adolescent health in Europe and Central Asia is really important. It has been recently highlighted by our, let's say, leadership, both in the WHO and the UNICEF context and beyond, by many member states and senior officials from member states. So this is really a need and a very important topic, reason why we are almost there to have a renewed strategy for child and adolescent health in the European region, also as a result of a great collaboration. So for us, this is very important, and I'm really grateful for everyone who participate. In the morning in Europe, good afternoon for our colleagues in Central Asia as well, if they are joining us. We are really, as I said, very excited with this opportunity here today. It's a critical moment for action. We know that children and adolescents across Europe and also Central Asia are facing incredible worsening health outcomes, and we have to be aware of that. Issues like the increase in obesity, childhood overweight and obesity, mental health problems, to declining even immunization rates in parts of the region. This was all exacerbated by, we know, the pandemic, climate change related health issues, persistent inequalities. They all call for action. So this webinar comes really at a very important time, I believe, to address or to contribute in a humble way, but to contribute to address these important challenges. We do have, particularly WHO, UNICEF, but I know this is also common for many stakeholders and member states, a shared commitment to transformation and to do more and better in this field of health. One of the most important, if not the most important, I would say, of health of children and adolescents across the WHO European region. So for this, we are very keen that we have the right collaborations, the right partnerships with different UN organizations, as I said, stakeholders, but also member states. And together we are really working in co-creating, also involving children and adolescent young people on the development of a new regional strategy, which is based on, as you know, the core 5 principles, from investing early to ensuring accountability, aimed at transforming how we support child and adolescent health and well-being across the WHO European region. We're all doing this with a very strong trust in science and with a very big focus on evidence, evidence to guide us moving forward. Today's discussion is informed, as it was very well pointed out and said by Susanne, by a series of draft fact sheets that we have created together, and they will spotlight the most pressing issues, but also opportunities for action. Taking the groundwork for policies that are evidence and data-driven, equitable, and responsive to the needs of every child and adolescent in our region. So I wish us all a great discussion here today. We would like to have an important debate. We would like to really inform even more the forthcoming strategy, and I'm sure that we will be in a much better position, not only at the end of this specific webinar, but at the end of this series. So have a great discussion. I will be with you throughout, and I wish us all the best for this webinar. Over back to Suzanne. Thank you.
Thank you so much, Joel. For the closing, we will also be joined by Octavian Bivol, the Regional Director of the Regional Deputy Director. I just promoted him for UNICEF Europe and Central Asia's Regional Office. He will be joining us for the closing. Now, as I said before, can I have the next slide, please? Just some housekeeping practical information. You can choose the language of your preference in the either the three dots on the bottom of your screens or this little world globe. And we have interpretation to Russian, Bosnian, Croatian, Montenegrin, and Serbian. Please, as I mentioned, we have 10 speaker lineup. Everybody will get only 5 minutes, and I will be very strict with the timekeeping. So we will have enough time for discussion and questions after the entire presentation. However, you may post your question and comments throughout the webinar in the chat by pushing this little speech bubble. I think you're probably all familiar by now how Zoom works. So next slide, please. Without further ado, I would like to, no, that's not entirely true. I need to do one more housekeeping point. Next slide. We have prepared for you a very interactive webinar, and we would like to invite you all to go on your mobile phone or computers to the website of Mentimeter. Go to www.menti.com and then enter the code on the left that I will read out in a moment, or use the QR code on the right. So the code is 89188643. We will give you a couple of seconds to join us on the Mentimeter slides. I see the thumbs up, so people are managing to join us, which is great. And then, without any further ado, please be ready for a series of questions and an interactive session. So I would like to hand over to our first speaker, Professor Ralf Weigel, a pediatrician who leads the Global Child Health Group at the Faculty of Health, the School of Medicine at the Witten-Herdecke University in Germany, and who was also the senior lead of the evidence review on child and oops, I'm not supposed to say that. Very good, I saved myself. Just to say that all these evidence-based fact sheets are actually based on a series of reviews that were commissioned by WHO to our WHO collaborating centers. Many of them you will see today here presenting the results. And And Ralph was the lead of one of these groups. And can you maybe mute yourself, please? Daedalus, thank you. And he's now going to ask the first question and present the results of the review he led. Thank you so much, Ralph. The floor is yours.
Thank you, Susanne, and thank you very much for the organizers for the opportunity to present our fact sheet. I also want to acknowledge my co-workers, Alice Hutzko, Fakhruddin Nizamov, and Michelle Black. I'm a little bit nervous now with that Menticom. Let's see if that works. We'll get started a little bit with interaction, I hope. So I guess you have all scanned the QR code or entered the code into the www.menti.com page. Can I have the next slide with the question, please? To get started, the question which should appear on your smartphone now or on your tablet, across all countries of the WHO European region, what is the variation in the rates of neonatal mortality? The three options we have: 2 times, 10 times, 28 times. I see responses coming in, so it seems to work. Thank you very much. That's wonderful. We have already 38 responses out of 78, and it's increasing. And we have a head-to-head between 10 and 28. Yeah, very good. Just give a few more seconds for the responses. Yeah. All right, maybe we'll get to 79 so that all attendees have a chance to vote. Yeah, well, that's exciting, 10 times. I'll propose now to close the vote, and the next slide, is it then already giving us the answer, Susanne?
Yes.
Okay, so the answer is 28 times is the neonatal mortality higher in the highest mortality country compared to the country with the lowest neonatal mortality. So that highlights the huge inequalities across countries in the region. So the purpose of our fact sheet on child and adolescent health mortality was to illustrate trends in mortality across the WHO Euro region. And for that purpose, we used data from the UN Interagency Group for Child Mortality Estimation, UNICME, from 2000 to 2022 of the 53 countries of the region. We formed 4 age groups: the neonatal age group, under 5 age group, 5 to 14, and 15 to 19 years. And then we calculated the WHO Euro median, which you can see here as the blue line, and then plotted the mortality rates on a graph showing here only country trajectories above the WHO Euro median. On the right side of this slide, you can see this exemplified for neonatal mortality. In addition, we defined for the 5 years from 2018 to 2022 a plateau as a decrease in mortality of less than 5% over that period, a decrease if mortality decreased by 5% or more during this period, and an increase is any increase of mortality. We found substantial differences between countries. For example, the 3 countries with the highest neonatal mortality rates in the region account for nearly a third of all neonatal deaths in the region. Over the past 5 years, neonatal mortality rates have increased in 6 countries in the region and plateaued in 3 countries with rates above the regional median. Now, looking at the under 5 mortality rates, they have increased in 4 countries and plateaued in 6 countries with rates above the regional median in the past 5 years. The median mortality rate for the age group 15 to 19 years increased in the region for the first time in over 20 years, with increases observed in 19 countries across the region. Next slide, please. So, what do these findings mean? It appears that gains in child mortality reduction in the past are being undone, and that's most apparent in countries with increasing mortality rates. The observed stagnation and regression of mortality rates in many countries may signal a weakening of child health systems, and finally, any death is a tragedy for the individual and the family. But child mortality also has consequences for the entire society. And therefore, actions at the health systems level are necessary, particularly at the governance level. For example, countries should reprioritize child health, especially countries with consistently higher mortality that are above the WHO Euro median with increasing or plateauing mortality. An analysis of mortality causes is essential for targeted action. For example, strengthening maternal and perinatal services, given that neonatal mortality contributes more than 50% to under 5 mortality overall. Implementation of a unified health strategy may help to strengthen the continuum of primary, secondary, and tertiary care, including health promotion, prevention, curative, and rehabilitation services. Valid indicators and high-quality data facilitate informed decision-making and are a prerequisite for holding decision-makers accountable. Child health professionals should be advocates for conflict resolution to tackle the root causes of intentional injuries, especially during armed conflicts. And finally, it is essential to emphasize that the UN Convention of the Rights of the Child serves as the foundation of our efforts to enhance child and adolescent health and well-being. Thank you for your attention.
Thank you so much, Ralph. So congratulations, Mentimeter worked well, and I think some of you might have been surprised by the answer. I will hand over now with the next question to our colleague from UNICEF, Fatima Shenchik, who's in charge. I cannot say because otherwise it will tell you, but she's presenting on behalf of UNICEF and WHO. Oops, next slide, please. I think the sharing stopped.
Good morning. Sorry, can I make a sorry, this is a little admin announcement. We just need to reactivate the interpretation. Apologies.
You let us know when we should continue.
I'm sorry, it seems we've lost one of the interpreters. I'll reactivate the presentation and we can carry on.
Thank you so much. Fatima, the floor is yours as soon as we see the slides again.
Thank you, Suzanne. I will try to be short, so to save some time.
Yeah, Ralph got some extra because he was first. Over to you.
Thank you so much. So from this, you will guess what I do, but here's the question. So 940 measles cases were reported in 2022 in the WHO European region. How many were reported in 2024 from January to November? So it's almost 10,000, more than 100,000, more than 10,000, but less than 100,000. So let's see, what's your best guess? If you've been following the news, you might actually very quickly answer this question. Okay, we're getting there. Great. So 20, 30 out of 81. I think we can get even higher. This is like one of those auctions. Come on, take the wild guess. 914 in 2022. How many in 24? What do you think? You don't need to be immunization specialist at all. Okay. Okay. Well, for the others, I think they might be shy now, but let's move on to the actual answer. We can stop the Mentimeter. Majority of you were, nah, not right. So actually, the number is 106,000. However, I want to emphasize that the data that we have put in the fact sheet is from January to November. But until the end of December 2024, we had 127,000 of cases of measles. And it was the highest number of cases we've seen in the last 25 years in the WHO European region. So clearly we have a big issue with this. And we've seen 38 deaths from these cases that were identified in our regions. So in terms of measles, only 11 out of 53 countries met the 95% target, which is actually European immunization agenda target that was set for the region, and it's generally epidemiological target that we usually use. But what we've seen is that outbreaks resurged in 2023, 2024. We also have a big problem with pertussis spike, 87,000 cases in 2023, which is highest since 94. And just 25 countries out of 53 in our region hit the 95% DTP3 coverage target. And in terms of equity gap, vaccine access remains really unequal, even in the high coverage countries that we often see, generally having a high coverage at the national level. Once we go at the district level and lower levels, the coverage is really problematic. Next slide, please. So why is this important? Why would we care? Well, first of all, children are dying of measles in our region. Secondly, vaccine preventable diseases can be really deadly, especially for young children under 5 who are the most vulnerable to severe complications. Vaccination has significantly reduced infectious diseases, but coverage must remain high to prevent outbreaks. And missing measles vaccination is a red flag. So what we often say in immunization world, measles is a canary in the coal mine. It's really early indicator of potential danger that we're facing. And clearly in our region, we're facing danger with the measles coverage. So these children often miss other essential vaccines and they face broader barriers to healthcare. So what needs to be done? First of all, we need to strengthen data systems to identify under-vaccinated children. We've reached a certain level of immunization coverage, but we need to push further. So we need to make sure that we reach the under-vaccinated children who are most vulnerable. We need to address barriers through local tailored solutions. One-size-fits-all approach does not work anymore, especially in our region. So we need to go back to finding solutions that work at the local level. We need to equip healthcare workers to effectively communicate about vaccines. We know that the healthcare workers are the most trusted source when it comes to vaccine information, and that's where we need to put our focus on. We need to work with the communities, so do more of the community engagement, partnerships, and innovation to really raise demand and awareness. Use also behavioral research to understand what drives or hinders vaccination. So we need to make sure that we understand what are the causes, what really drives this, and what are the parents thinking. And we need to increase funding for immunization in PHC. This is one of the best public health interventions we have. So every dollar invested gives a $54 return of investment. So we need to sustain the funding to immunization programs, and not just procurement of vaccines, but actually programmatic aspects of it. And enhance disease surveillance and outbreak response capacity. We talk about measles outbreaks. So we need to make sure that we react very quickly and we prevent further spread. Thank you very much, and I pass it on to Suzanne.
Thanks so much. That was Fatima from UNICEF, the immunization specialist. Thank you so much. I will now hand over to Sophie Julien, the Technical Officer for Child and Adolescent Health at the WHO Office for Europe, based in the WHO Athens Office for Quality and Care and Patient Safety. Sophie, the floor is yours.
Thank you very much, Suzanne. Good morning, everyone. Good afternoon. So we have seen already two topics, mortality, immunization. For the next one, we have asked children in the region to speak about one of the challenges and to make you guess with their own word without using the keyword, to make you guess what they are talking about. So they will make you guess what is the next key issue that we're going to talk about. So we will have the first video. Thank you, Jen. And after that, you will have in the Mentimeter a word cloud so that you can tell us which topic they are talking about. Jen. Thank you.
Makes them be strong later when they grow up, and them feel then really happy and loved, and it's really good for them.
Porque antes de o bebê nascer, o corpo já se prepara para ter esse leite.
A baby drinks from the breast from a mom. I don't get the stuff that the mom has, like the stuff that the mom drinks and eats.
And that's how it's always good and safe.
A melhor comida para os bebês é o leite que vem da mamã da mãe.
Das ist, wenn man an der Brust noch hält. Das ist, um zu leben. Das Baby, wenn es an der Brust nuckelt, bei der Mutter, wenn es trinkt. Die Brustmilch.
Thank you. So now we'll be back in the Mentimeter. The slide will be moved to the next in a second, and you will tell us what these kids are talking about. So you can enter one word. Which issue are we going to speak about? So it seems pretty clear because for now, from 23 replies, we have breastfeeding, 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 nutrition, diet, healthy eating. This is all what it is about effectively. And love, and quality life, and respect. So I think we are all in the same page. These kids were talking about the issue of breastfeeding. And obesity, and healthy eating, and mother life. Fantastic. So they made us guess the wrong topic. If we can move to the next slide, please. Thank you very much for all of you for participating in this word cloud. And so, yes, breastfeeding is the next key issue that we will tackle in the strategy. So breastfeeding initiation within the first hour of life is still not as it has to be in the region. You can see in this map that too many newborns are still not breastfed within their first hour of life. And we can see also in gray all the countries in which we are missing data. Next slide, please. So why is this important? I think it's very clear, but let me remind you. So delayed initiation of breastfeeding can have life-threatening consequences. We all know that breastfeeding decreases the risk of diarrhea, pneumonia, and asthma in the childhood and later in life. It also decreases the risk of obesity and non-communicable disease later in life. And as it was also mentioned in the word cloud by some of you, it contributes to the health and the well-being of mothers. We know all that, and still we have low rates of initiation of breastfeeding in the first hour of life, and our region has the lowest rates of exclusive breastfeeding in the world. What can we do? What needs to be done? We need to implement the standards that are set up by the Baby-Friendly Hospital Initiative. We need to comply with the International Code of Marketing of Breast Milk Substitutes. We need to support breastfeeding practices through paid leave and workplace regulations, among others. And we also need to invest in doctors, midwives, and nurses for breastfeeding protection, promotion, and support. We have some more in the fact sheet, and we will share the fact sheet at the end of the webinar, but this is over from my side at the moment. Thank you.
Thank you so much, Sophie. And thank you everyone for playing the Mentimeter. I will hand over for the next topic to Alexandra Jovic, specialist for early childhood development at the UNICEF Office of Europe and Central Asia. Alex, the floor is yours.
Thank you so much, Suzanne. And we can move to the Mentimeter question. We have one for this area of work as well. And I hope that it will be very easy for people following and joining Health Systems for ECD platform before. And the question is, what is the percentage of countries in the WHO European region that report offering early childhood development services for children? And for those of you who still didn't join Mentimeter, the Mentimeter link and the code are on the top. So you still have time. We would like to hear from as many of you as possible. So what do you think? What countries report about support to early childhood development? And it is not as interesting when you don't give us your opinions. We know that you know a lot. So we see that what is the majority is thinking that it is 50%. So we give it a little bit more time. So 50% still stays. So we can close, inviting you in the meantime, in the break, to join in larger numbers to the Mentimeter, and we can move on to the next slide, Suzanne. So although you said that, majority thought that it is 50% of countries who provide ECD services, countries report actually that is almost 100% of them report that they are providing services. And this is indeed very important given the high prevalence of developmental disabilities in children under 5, and over 5 million children at risk of developmental difficulties in our region. On the graph, you will see significant variations across countries that are pointing to differences in resources, exposure to children to developmental threats, but also differences in access to services and system effectiveness across countries. I'm sure that you already know that developmental difficulties in early childhood are significant contributors to morbidity and disability later in life. And it is therefore really important that health systems are able to identify developmental issues as early as possible in the child's life. But unfortunately, we also know that systems that would provide monitoring of child development, ensure prevention and early identification of risk factors, and finally, provide early childhood intervention are weak, fragmented, and poorly organized across the countries of Europe and Central Asia. Next slide, please. So early years are really the only window in which developmental difficulties can be prevented, and they can be effectively and efficiently addressed. So that increase the overall importance into the investments in early childhood development that yield high economic returns. But in the absence of investments, children cannot reach their full potential, resulting in a huge loss of human capital. Unaddressed developmental difficulties will lead to higher healthcare costs and increased burden of chronic disease. So what is that we can do about it, and what is that the successful governance will include. First, we need to guarantee support for early childhood development through all contacts with the health system, including routine well-child visits at home or through home visits. We need to empower parents as key agents of child development and well-being, and ensure that monitoring of child development and the provision of timely intervention for children with developmental difficulties also happens as a routine and are available to all. We need to promote key health interventions that include breastfeeding, immunization, responsive caregiving, and early learning opportunities that are essential for young children to develop to their full potential. And finally, we need to invest in well-trained health workforce that will be able to deliver early childhood development services in collaboration with other sectors. Thank you for your attention, and over to you, Suzanne.
Thank you so much, Alex. So while 100% of countries, or close to 100%, tell us they are doing something for early childhood development, clearly they're doing very different things with very different outcomes, and more must be done. I'm very pleased to now invite Professor Colette Kelly, Professor for Health Promotion and Director of the Health Promotion Research Center, a WHO Collaborating Center for Health Promotion and Research at the University of Galway, Ireland, who has also participated in led one of the reviews that form the basis of the new strategy. Colette, the floor is yours.
Thank you, Suzanne. And thank you everyone for attending. Good morning, good afternoon. So I think Sophie or someone is going to show another video. And if you could enter into a keyword into Mentimeter to, I suppose, guess what the young people are talking about.
They don't exercise, and they drink too much sugary drinks and eat too much sugary things, and candy and chocolate cake, vanilla cake, cookies and Tic Tacs and caramel cake, ice cream, cake. Can eat a little from it, but not too much.
Jo crec que si mengem, com per exemple, massa menjar, ens podem agafar massa pes. O si només mengem, per exemple, sucre, sucre i sucre. També ens podríem posar molt malalts.
Dass man nicht gut laufen kann. Dass man nur noch faulenzt, dass man nur noch im Bett liegt und nichts mehr macht.
I a vegades, si també agafem molt de pes, de grans ens podem tenir greus malalties.
Man bekommt Karies. Diabetes.
Any type of cake, actually.
So I think if you, look at the Mentimeter again to enter what you think the children were talking about. That's great, thank you. Don't be afraid. Great, thank you. So we're seeing overweight and obesity, and obviously the children were talking about diet and physical activity, yeah. And they also mentioned cavities, that's right. Yeah. Thank you. Okay. You could listen to those children all day. They were just amazing. So thanks. Yeah, I think so. Yeah, so overweight and obesity is, I suppose, central there, obviously influenced by many things that the children were talking about. So we might move on to the next slide, please. And yeah, the topic, the children we're talking about was overweight and obesity. And really, we have really good data from lots of different surveys, but in the fact sheet and in the paper that we wrote together with lots of other, colleagues from across Europe, we focused on data from the Childhood Obesity Surveillance Initiative and also the Health Behaviour in School-Age Children study. And these data sets are looking at children who are, I suppose, primary school age and secondary school or post-primary school age. And really the data are very clear. We have, an ongoing public health crisis in relation to overweight and obesity. And the graph here is showing our 11, 13 and 15-year-olds over 3 time points. This is the HBSC data. And clearly what we're seeing is no country is, well, we can't see it from here, but we know collectively no country is showing this a decrease in, or a significant decrease in overweight and obesity. And I think we have, I suppose, as I said, sort of comprehensive data to show the scale of the problem. Now, this graph here also shows, I suppose, the disparity by gender. So rates are higher among boys than girls from this HBSC data set. What this graph doesn't show, but what we have focused on in the paper that we have written, is the inequalities that we're seeing in overweight and obesity. So we see this both within countries and across regions as well. And what we have very good evidence for is that socio-economic position is a risk factor for overweight and obesity. So something that does need to be tackled. Could I have the next slide, please? So thanks. So why is this a problem? I think most of us know, but we see impacts, I suppose, across so many dimensions of health for children and young people: physical, mental, their social health. And so children that live with overweight and obesity, they're more likely to have poor emotional health outcomes, including low self-esteem, depression, anxiety, but also non-communicable diseases as well. And childhood obesity, as we know, is a strong predictor for adult obesity. And this is where we also see then the impact on our society, both in terms of participation in society, but also the economic impact on our healthcare system and services. So significant, both short and long-term impacts. But efforts to date have really focused more on individual behaviour change rather than on what we know impacts overweight and obesity, which is social, structural and commercial determinants of health. And by not, I suppose, working on those areas, that's why we're seeing limited success and growing inequalities. So what do we need to do? So we have good evidence that we need to invest in primary healthcare. So we need to support families and track and collect data. But we also need more investment in our schools where children spend a considerable portion of their time. So investing in and, I suppose, supporting health promoting schools, including universal free school meals. That is a social safety net for children. We also need to meaningfully engage with our adolescents. They are the ones who have, I suppose, the passion, but also I think the strength to unlock this political and policy paralysis around unhealthy food systems. We need more work on, so breastfeeding was mentioned earlier, but we need more work, I think, as well on promoting breastfeeding so that the discourse around breastfeeding and the culture around breastfeeding changes, but also supporting families as well. I think the fiscal and policy levers to enable healthy diets are key going forward. So marketing restrictions on unhealthy food and drinks, both online, but also in mainstream media. We also have very good evidence that taxes on sugar-sweetened drinks will impact on what children are eating and thus on overweight and obesity. Thank you, Sophie.
Thank you so much, Colette. And we see, or we start to see, how many of these issues are actually intertwined and interdependent. I would like now to invite Nicola Gray, the core shareholder of the UNESCO Share Global Health and Education, and also affiliated to the University of Huddersfield, UK, and the University of Clermont-Auvergne in France. Nicola, the floor is yours.
Thank you so much, Suzanne. Well, may we have our next question, please? Please go to your menti.com if you're not already signed on. You've got the code there at the top of the slide. And the question is, in the countries of WHO European region, school closures, for COVID pandemic control in 21-22 varied between countries from how many days? It's a good initial response here. What was it in your country? We already seem to have a clear winner. But is it the accurate answer? Please share your opinion in these last few seconds. Okay, thank you. May we have the next slide, please? And indeed, those who voted for 0 days to 340 days were right. It varied between 0 and 341 days, actually with an average of 138 days. Okay, a long time for many countries. May I have the next slide, please? So we had a wide variation in days of school closure across those European countries, and the data highlight for the fact sheet about the impact of COVID-19 on education was a question from the Health Behaviour in School-Aged Children HBSC survey cycle of 2021-22, and that was conducted at that time in most countries of Europe. On average, 27% of 11 to 15-year-old adolescents surveyed said that COVID-19 had either had a quite negative or very negative impact on their school performance, and that ranged from 16% in Serbia to 40% of adolescents in Kazakhstan. And there was some qualitative data in the survey, including a quote from a 14-year-old girl from Slovenia who experienced 157 days of closure, who said that schools have been closed far too long. It doesn't seem right to me that schools were closed first and opened last. And how do these responses relate to days of school closure? It's a great question. Well, 40% of young people in Kazakhstan, and it was near the top of the league in 202 days of closure, but it's not straightforward. Italy was the maximum of 341 days of closure, but only 21% of their students said about the negative impact. We need to do more, and our group will publish a paper on this complex topic later this year. But the headline that was assigned to the fact sheet was that health and education inequalities expand for school-aged children due to pandemic closures. And the HBSC study found that adolescents from less affluent families were more likely to report a negative impact on school performance than those from more affluent families. The European Commission in 2024 also reported that children from the most disadvantaged households experience 4 times larger welfare losses than those from the most privileged household, and that learning deficits were persisting and indeed worsening in the later stages of the pandemic. Students living with existing physical and mental health conditions experienced the most severe impacts of the pandemic, and you may remember case studies where some students actually found it very difficult to go back to school in those situations. So there are lots of intersecting factors and common themes reported by different agencies. Next slide, please. In the data about welfare losses reinforced the big theme for us, that school is more than a place to learn. Not only were many students not receiving the normal curriculum, but school was the place where they might be getting their only substantial meal of the day, somewhere where they felt safe, connected to peers, trusted adults, and somewhere to access health services, including vaccinations. The impact is more than educational. If you're familiar with milestones like the Lancet Commissions on adolescent health and well-being and the multi-UN agency efforts around the 1.8 billion campaign, then you'll know the evidence for the mutual benefit of health and education. So in normal times, if you are well, then you are ready to learn. In return, students who get a good education tend to have better health outcomes because maybe they get a good job. They live in an area with good housing and can improve their social determinants. Data linking more years of education to reduced adult mortality also now exist. Thus, disruption to education has potentially very long-term impacts. So learning from the ongoing impact of COVID-19 school closures is necessary to understand what we need to do in future health crises. So we might seek to understand the impact of school closures so that we know what to do in future crises. We support schools to focus on both academic skills and well-being, recognising their mutual benefit. We target enhanced support to students from lower affluence households and those living with physical and mental health challenges. We take steps to foster strong intersectoral workforce collaboration in schools, and we ensure that every school is a health promoting school adopting the WHO standards. So governments need to think carefully before closing schools. They should be the last institutions to close and the first to open, so that our children and young people are not deprived of their welfare services and social connection, as well as their education. Thanks very much, Suzanne.
Thank you so much, Nicola. So we have heard how schools are an important place, not only for learning, but also for health, and how many of the issues we have heard before could be addressed through the health promoting schools. I would like to invite our next speaker, Simona Ponte, Project Manager, Child and Adolescent Health at the WHO Collaborating Center for Maternal and Child Health, Volo Garofalo in Trieste, Italy, and also the lead author of another review, which topic I cannot disclose because, again, you will see another video, which will, however, be published hopefully later this year. Simona, the floor is yours.
Thanks, Suzanne, so much for your introduction. I'm very pleased to introduce the next topic of this webinar today through the short video you will watch. And then I will let you answer to the Mentimeter to guess the topic of the next discussion we will have. Please go ahead with the video, thanks.
I feel sick and tired. I want more and more to watch, but I also want to stop at the same time. It's just not a good feeling.
Dann siehst du nur noch ja, dann wird man süchtig.
Você deixa de fazer coisas importantes.
Sometimes I feel like I just sat the whole time staring at my head almost touching it, and I just need to work out and maybe go somewhere like on a soccer field.
Abans tothom, tots els nens salien a jugar al carrer i ara no hi ha ningú que surti a jugar al carrer. Tots els nens se queden a dintre e crec que això não é só. Eu me sinto sem assunto porque eles estão vendo fazer e eu sem assunto. Então,
I feel bored and ignored, and that's just really not fun, especially when you don't have brothers.
adeu!
Okay, these children are amazing explaining the topics all the time. And let's see with the Mentimeter what the people are answering and what issue the video is talking about. Let's see what is coming. Yes, screen time and digital media, social media, mobile phones, screens, and screen addiction, gaming, digital devices, mobile use phone, smartphone addiction. Yeah, but screen time, yes. Most of the people should have replied. Nice 42 of the 93. Yeah. Yeah, but I think the answer is correct. We have 47 answers. And yes, answer is correct. Screen time and social media is the next topic of the discussion. Please, we can maybe go ahead with the presentation. Yes, the digital environment. I'm very pleased to talk about this topic because it's one of the main focus of the recent research of our WHO Collaborating Center, as the social dilemma is, of the digital dilemma is a global dilemma and is actually increasing all across our region. In fact, we're seeing 11% of teenagers are affected by problematic social media use. And here you can see from the graph, which is the distribution of social media use categories for each country. This is coming from the Health Behavior of School-Age Children survey of 2021-22. You will see with the white percentage are non-active user, which is for most of the countries of the region is very low. And then in light blue, the active users, and the blue percentage are the intense user. And then you see the dark blue percentage, which is increasing are the problematic users. So these are some key facts. 1 over 3 adolescents are constantly online with other friends. And the being online is positively correlated with the age of kids and the family income. And is a fact that problematic social media use, not just social media use, has grown from 2018, when it was 7%, to 2022, so to 11% in 2022. 1 over 3 adolescents are playing on online gaming on daily basis, and 1 over 3 are playing for daily sessions or more than 4 hours. Girls are normally more prone to use social media, so to problematic social media use, and boys are normally more addicted to gaming, to video games and online video games. But overall, screen time starts very early, actually too early, because we have seen that only the 25% of the under 2 kids are meeting the WHO recommendation on screen time, and only the 33% of the age group of between 2 and 5 years old are meeting the WHO guidelines on screen time recommendation. Please, the next slide. Why is that so important? So the social media use and the problematic media use is correlated with important health outcomes of children and adolescents. We are now studying at our center in the next review that we are conducted, that is problematic social media use is linked with mental health issues, several mental health issues and developmental issues, sleep quality. It increases risk behaviors for children and adolescents like substance abuse. It is associated with a lower life satisfaction already from early age of children, as we have seen in the video, and can have a negative impact on the physical health because of musculoskeletal problems and the strong reduction of physical activity that the children are having. So also on academic performance can have a negative impact. So the negative effects can be lifelong. What needs to be done and what the successful governments should do, it should regulate digital technologies for children protection, and should have a better collaboration with industry to enforce age-appropriate contents and to reduce the marketing publications, so to have marketing restrictions in social media and online contents. Should align the health and education policies with the digital age that we are facing to have a good balance between online and offline activities of children and adolescents, and should implement screen time policies, national screen time policies, which are based on WHO guidelines. Should provide support to schools, to provide support to families, to identify those adolescents who are more at risk, and should introduce digital literacy, from already the early childhood, because we have seen that children are exposed to screen very early, already before 1 year. and should set clear rules for smartphone use, should restrict the smartphone and tablets use in schools. So these are some key facts of the effects of digital environment on the children and adolescent health in our region. I hand over to Susanne, and I will be happy to answer to your questions. Thank you.
Thank you so much. I will hand over straight to our next speaker, Professor Alina Kosma. We are particularly pleased you're here with us, Assistant Professor at the Trinity Centre for Global Health, the Trinity College in Dublin, Ireland. Alina, the floor is yours.
Hi, thank you so much, Susanna. So we're going to move again to watching one of these splendid videos of young people. And after that, we're going to ask you to tell us what the young people are talking about. So if you can go ahead and share the video.
Eu tenho uma amiga que ela se sentiu muito triste.
It makes me feel bad. Mostly I should help them, but maybe they just need to be alone right now and need to think about something.
Para as pessoas ajudaria muito de elas ficarem com alguém que elas gostam daquela pessoa, que elas amam aquela pessoa, ajuda da família dela.
Friends, family, people to talk with, and people that they can say how they're feeling and what makes them sad and how and all that.
Meine Eltern. Kuscheln.
Eu acho que elas poderiam ir no psicólogo para elas se sentir melhor, porque o psicólogo poderia ajudar elas a elas se sentirem melhor por muito tempo também.
Somebody to play with, and somebody to have, and to just do stuff with them.
Yeah, these kids are amazing. If we can have the Mentimeter. So what issue are we talking about now? Yeah. Oh, yeah. Yeah. This is good. Yeah. 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 I think the direction goes the direction of responses go, or the responses go in the direction that we've expected. I think we can close the Mentimeter and then move on to
Is that me or are you breaking off? I'm sorry, we cannot hear you. Okay. Should we, Alina is having trouble with the connection. Should we maybe continue and we come back to your slides, Alina? Okay, so maybe, okay, so once she's back, we will come back here. I will
Sorry, I'm back.
Oh, you're
Hi.
back. Yep.
Yeah.
Great. Okay,
Yeah,
go
no,
ahead.
my internet had a stroke. So as you well pointed to, the next section will be about mental health, and you see that in these stories that young people had put forward, there's a lot of focus on actually what could be done to support their mental health. But I suppose looking at the evidence, what we know, and it's something that both the recent Lancet Commission on Child and Adolescent Wellbeing, the Lancet Commission on Adolescent Mental Health has pointed. We know that the adolescents today have poorer mental health compared to previous generation. And this is something that studies such as Health Behavior in School-Aged Children has shown that across the countries, both within and between countries, we can see that there's this increase in mental health problems and a decline in mental well-being. And when we look at these trends, we can see that especially the girls have the girls' mental health has worsened over time. But also when we look at the most recent, for example, HPSC data that collects data in 45 countries within the European region, we see some remarkable patterns across the countries and across the indicator, both of mental health problems, but also of mental well-being. We can see that girls report worse outcomes than boys, with increasing age, especially when we talk about middle adolescents, those aged 15 to 16-year-olds, they report worse mental health than their younger peers. And there's a systematic social economic patterning, meaning that those adolescents that grow up in low affluent families report the worst mental health outcomes. But also when we broaden the way we look at mental health, we know that suicide is one of the top leading causes of death among adolescents, alongside injuries and accidents. And a recent report from the regional office in Athens has shown that almost half of the young people have unmet needs in mental health care in the countries in Europe. And when we look at the access to services, there is limited access across the region. And also when looking at the quality of care that these young people have across the region, this is highly inconsistent across countries, but also within countries. So what needs to be done? Next slide, please. So this is extremely important, as mental health is a top priority. If you speak to any adolescent, they would say that mental health is one of the top priorities. And as I said, this is highly patterned by socioeconomic inequalities, gender inequalities, and there's also age variations. But when we take that step forward, we know that half of the adult mental health disorders have their onset before the age of 14, and 2/3 of these mental health disorders would have had their onset before the age of 24, which really points out to this early support that is critical to ensure that young people would have a good mental health across their lifespan. But also we know that if we address these mental health problems and promote their mental health at this key age stage, we would therefore prevent sort of school failure, we can prevent substance use later on, unemployment, social exclusion, and we know that mental health problems are one of the more important drivers of those DALYs, the years lived with disability in young people, which we can really address. And when we look at suicide and the fact that so many adolescents die because of suicide, this is extremely important and it needs to be addressed. So what needs to be done? So on one hand, it's extremely important that countries and ministries of health and governments continue to increase their investment in adolescent mental health services. And this both when looking at national level, but also when we look at local and community levels, so that there's that sustained support for outcome services. We know, as I pointed out, the social determinants of mental health are extremely important, but we need to widen the way we look at this and also focus on digital, commercial, and structural influences of mental health. And especially when we look at what happens on the online environment, that needs to be better regulated. And this is something that Simona has pointed out earlier. Given the social economic patterning, there is this increased vulnerability for families that struggle to meet their needs and their ends, and therefore there needs more support to be given to these vulnerable families in terms of social and financial support. And this has to come through coordinated and multi-sectoral action. And given the priority that young people put on their mental health, we need to increase the access to youth-friendly services across and within countries, including improving the access to counseling and psychosocial supports through school and community settings. Also, we can work with schools, such as health promoting schools, to really strengthen this life skills education, provide perhaps more support to caregivers, and build those social emotional learning skills. And we can do this by having these embedded in programs from early on. And lastly, given the sort of the extent of the problem, there's more need to really work with primary care providers to really help them and empower them to identify and manage mental health problems among adolescents early on. And if we do all this, we can really improve the quality of care from early on, and therefore prevent this cascading effect later on in the adulthood. Thank you, Susanna.
Thank you so much, Alina. And from here, we will go right to the next slide, please, and the next topic. Next slide, please. So we heard we need more good primary care to tackle some of these issues, particularly mental health, but also many of the others. So let's see, what is the percentage of WHO European region countries that allow adolescents access to health services based on their maturity, meaning without parental consent, which is actually enshrined in the UN Convention on the Rights of the Child that all our countries have ratified, that actually says that adolescents should have access based on their evolving capacities. So is it less than 25%, more or less 50%, or almost 95% of countries who report that they allow adolescents access to health services based on maturity? There seems to be the winner of 50%. Okay, given that we are running late, show us the answer. It is actually less than 25% of countries. Next slide, please. And here you see the maps. The ones in green are the ones that reported that they allow access based on maturity. Then the yellow ones, 14 to 15 years, orange, 16 to 17 years, and red, 18 years and older. And the gray where we have no data. Next slide. So why is this important? Well, as I have said, apart from that it's a right for every adolescent, and all our countries have ratified the UNCRC, it is also very important for some of the services like mental health, like the decision to get a vaccine or not if your parents don't want you to get vaccinated. So there are good reasons. We obviously don't, wherever possible, it's good for parents to be involved in the care of their children, but it might not always be in the best interest of the adolescents to have to ask their parents for permission. So, and this access should be based according their development, their maturity. If they understand what these healthcare services mean, then they should be allowed to consent to them. So what needs to be done? As we have seen, there are many countries that should bring their legislation in line with the Convention on the Rights of the Child. They should allow mature adolescents to consent or to refuse to treatment without parental involvement. And to do this, we obviously need a health workforce that is competent in deciding whether or not an adolescent is mature, can consent to the services. And as mentioned by Alina just now, we need more adolescent-friendly health services. We need doctors and nurses who are trained in these services, which is particularly important for mental health, but also for dealing with problematic social media use, for dealing with overweight and obesity, and many other concerns. We need to ensure that consent and confidentiality is carried out in the best interest of the adolescents in all primary healthcare interactions. Next slide, please. As you can imagine, this topic is actually very relevant for not only mental health and vaccination, but also for sexual and reproductive health services, because these are the ones that are sensitive, and adolescents may not always feel comfortable discussing them with their parents. Now, let's see for a moment, in our regions, how do the legal ages for accessing contraceptives to the age for being held responsible for a crime compare? Do we allow adolescents, usually at the same age, to be competent for their care and to be held responsible for a crime in case they commit one? Or second, in most countries, the legal age for accessing contraceptives is actually higher than the age of criminal responsibility, or in most countries, the legal age for accessing contraceptive is lower than the age of criminal responsibility. And we have a clear winner here. Please show the correct answer. Yeah, unfortunately, and actually, from my point of view, quite surprising, you can go to the jail or prison before you can actually decide about your health in many of our countries. Next slide, please. As said, that is particularly important for sexual and reproductive health services. And we see that there are many barriers in many countries due to restrictive laws, limited access to free contraception, and particularly emergency contraception, limited also sexual STI testing and counseling, and inadequate access to free HPV vaccination. Now, these are issues that go beyond the only question of the legal framework for access, but that is regulating all of this. One other point that this fact sheet is making is that comprehensive sexuality education is actually not available in all our countries' school curricula. Next slide, please. As you notice, I'm rushing you a little bit, but I want to be there at least a little bit time for question and answers. So please refer to the fact sheets for more detail. So I will not go into much depth on why comprehensive sexuality and direct access to comprehensive sexual and reproductive health services is important, but we know that it actually prevents unintended pregnancy and reduces health risks for young mothers. It does not increase promiscuity or lowers the age of first intercourse. Actually, the contrary is true in most of countries that do have comprehensive sexuality education and that do allow adolescents access to care based on maturity. We see actually less unintended teenage pregnancies, and we also see increasing age of first sex. So what needs to be done? We need policies and laws that actually ensure access to sexual and reproductive health services without third-party consent for adolescents. We need comprehensive sexuality education in schools. We need policies that allow free access to contraception, including emergency contraceptions. We need adolescent-friendly health services, and ideally in the primary healthcare level as well as in schools. and the new WHO UNICEF strategy is hopefully making great strides in this area. Next slide. I will now hand over to our last speaker, Dr. Amy Stevens, Public Health Lead at Bevan, a UK-based non-for-profit organization that provides health and well-being services for refugees and people seeking asylum. Amy, over to you.
Thank you, Suzanne, and hello, everybody. So I think we've got another question on the Mentimeter when the slide comes up. And the question is, between 2021 and 2023, the number of forcibly displaced children in the WHO European region has A, stayed more or less the same at a high level, B, almost doubled, or C, increased by 1.5. And just whilst people are submitting their responses, I just wanted to highlight that it's World Refugee Week this week. So we're celebrating the contributions and resilience of refugees and people seeking sanctuary all over the world. So I know we're focusing on challenges experienced by forcibly displaced children today, but we mustn't forget the positives that people bring to host countries as well. I'm conscious of time, so thank you very much for responding. And yes, everybody's correct. The numbers have almost doubled. We go on to the next slide, we can see a graph which shows this as well. So there are an estimated, or in 2023, there are an estimated 9 million forcibly displaced children in the European region. So geopolitical, economic and climate crisis worldwide are having a catastrophic impact on children, and we're seeing this increasing number of forcibly displaced children. Forcibly displaced children include refugees, children seeking asylum, internally displaced children, and also stateless children. Next slide, please. So why is this important? So the experiences of forcibly displaced children pre, during, and post-displacement or migration can have a significant impact on their health, well-being, and their development. So many children who've been forcibly displaced have fled war and conflict, persecution, natural and environmental disasters, abuse, exploitation, and significant poverty. Many may have experienced violence towards themselves. They could have witnessed violence of family and friends, or they could have been forced perpetrators of violent acts themselves, for example, in the case of child soldiers. Many of them have endured long and dangerous migration journeys. They could have been exposed to physical and sexual violence on their journeys, often stayed in overcrowded refugee camps, and had limited access to adequate food, sanitation, and healthcare. And unaccompanied children in particular may have been exposed to exploitation by traffickers and people smugglers, with cases of forced labour, sexual exploitation, and even organ harvesting. And despite international law to the contrary, at least 40 countries within the WHO European region detain children for immigration purposes. And there's a wealth of evidence that shows that's detrimental to a child's physical and mental health. And these risks to health and well-being can persist post-migration as a consequence of immigration policies, poverty and poor housing, systemic racism and discrimination, and healthcare access barriers. And those barriers include things like restrictions on service entitlements, out-of-pocket expenses to access healthcare, and also language and cultural barriers. And we do explore this in the review paper that's coming out later this year. And refugee and migrant children are often denied their rights as outlined in the United Nations Convention on the Rights of the Child. And it can be challenging for countries hosting large numbers of migrant children to meet their health, social and education needs. And challenges include things like underfunded public services, workforce shortages, and also a lack of data to inform evidence-based policies and practice. Yet we know that failure to care for child refugees and migrants is a missed opportunity for national economic growth and productivity. And Ralph touched on this as well, that importance of investing in children and young people. And so what needs to be done? So countries need to honour commitments made in the UNCRC, and that requires cross-country collaboration, national government commitment, and inclusive, accessible and adequately resourced public services. And it's absolutely imperative that action is taken to protect children during armed conflict, and that also cross-sector emergency preparedness and response plans account for refugee and migrant children's needs. And it must be remembered that child migrants are children first. Quality healthcare, social protection, education, and a safe environment should be provided to all children, irrespective of their immigration status. Countries need to collaborate to address the issues that cause forced displacement, conflict, climate crises, food insecurity, poverty, and health inequalities. And furthermore, there needs to be an increase in the availability of safe and legal migration routes to avoid children having to make these traumatic and often dangerous journeys. And finally, host countries need to collect data disaggregated by migration status, age, and sex to inform responsive policy and practice that addresses the needs of this population. So thank you for your attention, and I'll hand back to Suzanne.
Thank you so much, Amy. Thank you, everyone, for speaking fast. We had a very packed agenda. We got through it. I see that there are many questions that have been answered already by my colleagues in the chat. I think that probably has to suffice for today, but please feel free to continue asking questions in the chat, but I will hand over now to Sophie for some more information and then the closing.
Thank you very much, colleague and Suzanne. So as she just mentioned, please continue. We will reply the questions in the chat. And as well, we will, if I can have the next slide, please. You've heard about the fact sheet. Here they are. You have the QR codes, so you can access all of them, which are published already in our website. And so all those have been developed, as you very well know by now, to inform the new UNICEF WHO strategy for the European region. And a few more are about to come. So please keep posted. We will also obviously announce them in the social media so that you can have access to them. I would like to also reinforce what you have heard, that the fantastic speakers this morning and this afternoon have led a series of reviews to expand the topic. These reviews are under review at the moment, and they would be published by the end of the year. So we will also keep you posted so that you can have more information on them. Next slide, please. And a few words of information. So this is the first webinar of a series of 3 webinars. Please take note that the following 2 webinars will happen on the 10th of July and the 16th of September, all of them at 10 a.m. CET time, so same time as today. In the second one, we'll be speaking about the content of the strategy, and on the third one about the implementation challenges, approaches with the youth engagement. Also, just to remind that all the materials of the webinar will be shared in the platform that has been shared in the chat right now. And please subscribe to the ISA newsletters if you would like to receive updates, and so that you can also keep posted on the invitation for the forthcoming webinars. And so without further words, let me thank you again. And I'm very pleased now to give the floor to Octavian Bivol, the Regional Deputy Director of UNICEF Europe and Central Asia, for the final words and the closing of the webinar.
Thank you very much, Sophie. Do you hear me well?
Yes.
Perfect. Colleagues, friends, I'm absolutely delighted to join this webinar, the first webinar in the series of 3 webinars, as it was announced already, organized under the Health System for Early Childhood Development Initiative, together with the colleagues and friends from WHO Europe, but also International Step-by-Step Association. We are very glad that this community of practice established around the health systems for early childhood development platform is expanding, and we're looking forward together as partners to continue growing it and to use this platform to raise awareness, advocate and exchange knowledge on health and well-being on children and young people. I was very impressed by the energy and the speed also of presentations, and I understand it was I was able to join only at the tail end of this webinar, but I understand there were excellent presentations around the fact sheets that have been put together in collaboration and partnership with WHO to review the evidence, statistics, and figures, but also the commitment and the large number of participants in this meeting, still more than 100, around 120 participants at the end of this meeting, shows the commitment, the interest, and I'm sure the passion about this topic, which is directly contributing to the new strategy on children and adolescents health, which is jointly developed by WHO and UNICEF, and of course with participation of all experts, all of you, and in consultation with member states and young people. We were very pleased to get the inputs of young people as well. And I'm sure the discussions today underlined once again why it's so important as children are facing old and new challenges which are becoming more complex and interconnected, including impacts of climate change, inequities, mental health crisis. And I was also listening to the last presentation on displacement and migration, which is only underlying how important this work on the child and adolescent health strategy is. And of course, I would like to mention perhaps three important elements which make this strategy really important. One, it means that we need to invest early and consistently in children and adolescents. We know that early investments are providing not only the best start in life, but it's also one of the most powerful equalizers later in the life cycle. It leads to healthy and more equitable societies. It's important because it promotes multi-sectoral actions, and we know that the health is not only the accountability of health sector, but engagement of experts either on education, urban design, or food systems, and others are equally important. And final point, we aim at having at a strategy and an agenda which is ensuring accountability, mutual accountability. So it's really we can only have good policies which are leading to real results. So in conclusion, I would like to really thank our partners and to thank all of you for joining this webinar, and we will continue engaging through the next two webinars, leading to really shaping up and promoting the strategy, because the strategy will only succeed if it's embraced, it's understood, it's supported by all of us, by all of you as distinguished experts and policymakers on children and adolescent health. So looking forward as UNICEF to stay connected and supporting these efforts. And thank you once again to all for what I understand has been a very rich and substantive discussion today. Looking forward to the next two webinars. Thank you, and back to you, Sophie.
Thank you, everyone. And we will see you for the next webinar.